This morning, the U.S. is a nation in crisis. Amid a global pandemic and record unemployment, now comes unrest unlike anything we've seen in a generation.
Hello, and thank you all for joining us today. On behalf of the American Cancer Society Cancer Action Network, welcome to today's CBCF Annual Legislative Conference panel discussion on the impact of COVID-19 on cancer screening. I am Keisha Brooks-Coley, Vice President for Federal Advocacy and Strategic Alliances with the American Cancer Society Cancer Action Network, and I'm going to kick off our session. During our panel discussion today, we will be talking about routine cancer screening and how they play a significant role in the early diagnosis of various cancers, including breast, colorectal, lung, and cervical, and how COVID-19 has impacted screening rates. When we examine screening rates, we know that early detection of cancer through screening reduces mortality rates. However, access to these potentially life-saving screenings is not always equitable, which creates significant disparities in cancer incidences and outcomes. And we also know the consequence of such disparities is that cancer is more diagnosed at later stages when options for treatment may be limited and the odds of survival decreased. For example, breast cancer is more likely to be found at an earlier stage among white women than among Black women. And Black women and white women get breast cancer at about the same rate, but death rates, however, are 40% higher for Black women. Additionally, we know that Hispanic women are 40% more likely to be diagnosed with cervical cancer and 20% more likely to die from cervical cancer as compared to white women. These statistics confirm that screening is imperative, and we know that screening can save lives. While cancer affects everyone, we know it does not affect everyone equally. Similarly, the same is true for coronavirus. Communities of color are disproportionately affected by COVID-19 due to pervasive pre-existing health and socioeconomic disparities. These same disparities also cause gaps in cancer incidence and mortality rates between different populations. People of color are more likely to be uninsured and face barriers to quality health care, including access to testing and treatment needing for early detection and intervention of coronavirus. We must address desperate outcomes in the context of the pandemic, and sustained, comprehensive policy changes are needed to address long-standing disparities in healthcare, especially in the cancer continuum. At the beginning of the pandemic, elective medical procedures, including cancer screening, were largely put on hold to prioritize urgent needs and reduce the risk of the spread of COVID-19 in healthcare settings. However, one consequence of this has been a substantial decline in cancer screening. Given that Black Americans have the highest death rate and shortest survival of any racial and ethnic group in the US for most cancers. Screening and early detection is a must. Regular cancer screening remains important even amidst the pandemic. As states continue to ease restrictions, restarting cancer screening requires careful consideration of the risks and benefits for patients and for health professionals. Decisions about restarting screening depend on many factors, and those factors may not be the same for every person or every community. However, conversations like this one and education and awareness are imperative. Today's discussion focuses on the importance of cancer screening, the impact of social determinants of health and COVID-19 on cancer screening rates in the Black community, as well as strategies that can be used to restart screenings in communities. I'm pleased to be joined today with an esteemed panel. We have Dr. Dorado Brooks, Vice President for Prevention and Early Detection with the American Cancer Society. We have Dr. Stacy Fedowa, Senior Principal Scientist for Surveillance Research with the American Cancer Society. And we have Ashley Brown, Director of Health Equity and Stakeholder Engagement with the American Cancer Society. And we also have Dr. Lisa Richardson, Director of the Division of Cancer Prevention and Control with the Center for Disease Control and Prevention. Each panelist this afternoon will give 3 to 5 minute remarks, and then we'll move into a question and answer section of the program. So let's go ahead and begin. Dr. Brooks.
Thank you, Keisha, for that kind introduction, and thank you for allowing me the opportunity to speak on this very important topic. As everyone is aware, on March 13, the U.S. declared a national emergency due to COVID-19. The Centers for Disease Control at that time recommended that healthcare visits be prioritized to urgent and non-elective care. The American Cancer Society actually, for the first time in its history, recommended against individuals going to healthcare facilities for cancer screening, and a multitude of other organizations made similar recommendations about avoiding cancer screening. The impact was immediate and pronounced. These are estimates, so all of these numbers come from a variety of different sources. The main thing to keep in mind is not the exact number, but the trend, and the trend has been steadily downward. A variety of different sources indicate that decreases of anywhere from 80 to 90% for breast, colorectal, and cervical cancer screening compared to in 2019 over the same period of time. This slide shows the drop in colonoscopies in a number of different health systems monitored under a specific EHR program. This showed a drop in colorectal cancer diagnoses of over 30% compared to the prior year. This was in early April. Another study estimated that 46% fewer cases of cancer were diagnosed in 2020 and between early March and April compared to the same period in 2019. And as you can see, this included colorectal, lung, breast, pancreatic, and other cancers. It's been estimated based on these variety of sources of data that more than 22 million screening tests did not take place between early March and early June of 2020, and that this will result in more than 80,000 cancer diagnoses potentially being delayed. The National Cancer Institute has estimated that more than 4,500 excess deaths from colorectal cancer and about 5,500 excess deaths from breast cancer will occur by the year 2030 as a result of these delayed and misdiagnoses. And it should be stated that all of these estimates were predicated upon returning to a normal rate of screening by June of 2020. And as everyone is aware, in many parts of the country, we continue to have challenges accessing elective care, including cancer screening. So a number of challenges have been unmasked. One, we have an unprecedented backlog. All of those people who miss cancer screening opportunities still need to get screened, as well as individuals who develop new symptoms needing procedures, individuals who had abnormal findings on screening exams prior to the onset of the pandemic, who now need follow-up care. We continue to have varying local policies in capacity, in part related to fluctuating infection rates. There are patient fears and reluctance and confusion to re-engage with the healthcare system. The shift to telehealth offers some opportunity, but also provides new complexities for both providers and patients. There also are concerns about a potential loss of capacity in the primary care system, as many older clinicians facing the challenges of dealing with a post-COVID practice environment may choose to shutter their doors. There also has been a staggering loss of employment, and along with that, loss of employer-sponsored health insurance, meaning many individuals who need cancer screening may no longer have insurance coverage to support that. And finally, we have the exacerbation of long-standing inequities in cancer screening and follow-up and cancer care overall. In response to this, the American Cancer Society has established some strategic goals for our organization, specifically as it relates to COVID and cancer, with a strong focus on cancer screening. And we will be pulling together organizations from across the public health and governmental sectors to work on how to best improve cancer screening, how to stimulate research as it relates to COVID and cancer screening, and also focusing on the telehealth and telemedicine and ways that we can utilize this technology better in the cancer realm. Cutting across all of these issues will be a focus on racial, ethnic, socioeconomic, and geographic disparity reduction.
Thank you, Dr. Brooks. We're going to now move on to Dr. Fedewa.
Thank you. And you heard earlier from Dr. Brooks on COVID's immediate impacts on cancer screening, and I'll be presenting a little bit more in detail on the parallel economic crisis and its potential impact on access to care, cancer screening, and disparities. And before I get to that, I just wanted to talk a little bit more in general about access to care and cancer screening to provide some context, as well as talk a little bit about some of my research group's pre-COVID work. Lack of health insurance is a barrier to cancer screening. For example, uninsured people are half as likely to be up to date with colorectal cancer screening and are twice as likely to be diagnosed with an advanced stage cancer. And Black persons are more likely to be uninsured than whites. This long legacy had the potential to be eliminated or substantially mitigated by improving insurance coverage for Americans with the Affordable Care Act that passed in 2010. The Affordable Care Act had several provisions, and indeed insurance coverage has improved for everyone, but one of the largest provisions was expanding Medicaid eligibility. In 12 states chose not to adopt Medicaid expansion. These states are shown in the orange or yellow coloring on the right side of the screen. And you'll notice that a lot of these states that haven't expanded Medicaid are located in the Deep South and are home to many African Americans. In a study that we published last year, we found that colorectal cancer screening among low-income people increased at a greater pace in 6 states that expanded Medicaid the earliest. So these 6 states included California, Connecticut, and Minnesota are some examples, compared to states that didn't expand Medicaid. And when we calculated the ultimate impact on colorectal cancer screening, we found that among the states that expanded Medicaid early, it translated into about 236,000 additional low-income people getting screened. And had the same improvements been observed in non-expansion states, 355,000 low-income adults would have been screened for colorectal cancer than what was observed. So next, current situation, the unemployment rate spiked to 15% in April 2020. And despite modest declines over the summer, they remain at historical highs. I know that these numbers are changing every month. According to the Bureau of Labor Statistics, averages through April through June, which is Q2, 13% of all Americans were unemployed, but this rate was higher among Black or African Americans, as well as Hispanic and Latinos. And we wanted to know how this economic crisis and unemployment situation would impact cancer screening, so we conducted an ongoing study to address it. We found that unemployed adults are less likely to be up to date with breast and colorectal cancer screening. For example, 60% of unemployed adults were up to date with colorectal cancer screening compared to 50% of unemployed adults. And we wanted to know if this association was accounted for by non-modifiable factors like age or sex or race, or modifiable factors like insurance. And I know this is a busy slide, but the main point is that if the little bars cross the gray line, there's no difference between the unemployed and the employed. And we found that after we accounted for those non-modifiable factors like race or age and sex, it didn't change this employment difference in screening, but after we accounted for insurance, it did. So we found that insurance actually buffers the association between unemployment and cancer screening. So in conclusion, this has policy implications. As I showed earlier, we observed that Medicaid expansion can improve colorectal cancer screening rates at a population level. And with the COVID-19 pandemic, there's an increasing number of unemployed adults, especially in Black and Hispanic people. They may need insurance through Medicaid. And as we see, insurance can actually help buffer the association between unemployment and cancer screening. But the bad news is 12 states haven't yet expanded Medicaid. So I thank you for that and look forward to the Q&A.
Good afternoon, everyone. My name is Ashley Brown. I'm the Director of Health Equity and Stakeholder Engagement for the American Cancer Society. I'm going to share a bit more about how the American Cancer Society works to advance health equity. I think it's important to understand our work in the current context. So the American Cancer Society believes that everyone should have a fair and just opportunity to prevent, find, treat, and survive cancer. We believe that equity is not the same as equality. Equality is providing everyone with the same tools and resources, but to achieve equity, individuals and populations with the greatest needs and least resources require different but not equal effort and resources to improve their health. At ACS, we have a strong history of speaking to and addressing health disparities and helping communities fight cancer. So again, this is how we define health equity. So attacking cancer from every angle requires us to attack cancer in every community for everyone. And we do this through our research, our programs, our services, and our advocacy. Through our research, we accelerate new discovery and implementation through data science, population science, and extramural discovery science. For controlling cancer, we have implement evidence-based strategies in prevention, early detection, cancer treatment, and survivorship to improve population outcomes. And through our advocacy, we advocate for public policies related to access to care, prevention, and research. Ultimately, we have a goal of decreasing cancer mortality by 40% by 2035. But we don't do this work alone. Collaboration is critical, and we leverage our convening expertise. We have national and corporate partners, sorority and fraternity and faith-based partners, and we look to leverage local partners as well as needed. As the speakers before me said, we know that great disparities exist in cancer screening and mortality for the Black community. ACS documents these disparities through our research, including our facts and figures pictured here, the report which helps us measure our progress toward health equity. We also know that COVID-19 is disproportionately affecting people of color, Black people specifically, and will likely increase these disparities across the cancer continuum. For ACS, it's really important for us to address and advance health equity by addressing the social determinants of health. We know that health is more than health care. Structural barriers such as racism, classism, and ableism greatly impact the social determinants of health, such as access to housing, transportation, and healthy, affordable foods and quality health care. We work to advance health equity through many examples pictured here, though this is not an exhaustive list. We provide technical assistance for community health centers to promote breast and colorectal cancer screening, for example. We provide cancer information and materials. We address housing needs through our Hope Lodges, and we educate the public about the benefits of Medicaid. We also advocate for healthcare coverage. In addition to that, ACS is leading 12 pilot community projects that help us work closely with a group of volunteers and community members to address some of the social determinants of health listed here, such as access to affordable healthy foods and transportation, and come up with a plan to address them. These are community-based initiatives. We're working with communities like the community of Jackson, Mississippi to address food insecurity, resulting in cancer and obesity inequities through an assessment, education, and awareness. And as a result of this, as a result of COVID-19, this project has pivoted to meet the immediate needs of different communities, especially leading in Jackson. In addition to the programs listed on the previous slide, we have a program called the Change Program, which increases access to cancer screenings and reduces cancer-related disparities in underserved communities. These programs are currently being conducted in all 32 NFL markets. And we know that since 2011, Change grants have supported the implementation of 3.2 million evidence-based interventions in our healthcare systems and contributed to almost 1 million cancer screenings across the nation. And again, Change grants build community and systems capacities to promote health equity, access and navigation to screening resources with underserved communities, increasing access to timely cancer screenings and appropriate follow-up care. One of the strengths of the ACS is collaborating with healthcare systems. So we work to advance breast health equity through our community grants and learning community. We're collaborating with Pfizer to fund quality improvement projects that reduce disparities impacting Black men facing prostate cancer. And we're also looking at how we can better address racial disparities in cancer care. And at ACS, our mission is to save lives, celebrate lives, and lead the fight for a world without cancer. And if you put a health equity lens toward that, we believe that no one should be disadvantaged in their fight against cancer because of how much money they make, the color of their skin, their sexual orientation, their gender identity, or their disability status. So to ACS, health equity is not just our mission, it's what we believe in.
Okay, thank you so much, Ashley. That was extremely helpful to hear about the work that is going on at ACS. We'll now turn to Dr. Richardson.
Thank you, Keisha. And thanks to the organizers for inviting me to come today to talk about what CDC does. A lot of data has been shared today about cancer, disparities, and all of that. So what I want to talk about today with you all is to share what CDC is doing, what our resources are, and what we have to offer. So DCPC provides, the Cancer Prevention and Control Division provides support and funding for cancer prevention and control programs at the national, state, and local levels. Foundational programs will bring together a network of cancer control partners to provide cancer screening services and to assist in environmental changes. We know from our work and what we've heard other speakers say today that cancer does not impact everyone in a similar way. And the COVID-19 pandemic has turned the national spotlight on the disproportionate burden of illness and death among racial and ethnic groups, but these challenges are not new, as we've heard from others. CDC and other organizations have been tracking these differences and working to improve health equity for many decades. Over the last 20 years, cancer death rates have dropped by 26% overall, and they have dropped for all groups, but the gaps still remain. There's still a lot of work to be done. We use data from our National Program of Cancer Registries and other sources to inform the work that we do to reduce risk factors for cancer and to impact cancer outcomes at the population level. We work with partners across multiple sectors to translate these data into evidence-based, culturally relevant strategies to reduce cancer risk and find cancers earlier when chances of survival are better. You see there on the left of the screen, the National Breast and Cervical Cancer Early Detection Program is celebrating its 30th year this year. Those on the panel today were helpful in getting this program started. We provide screening and diagnostic services to low-income, uninsured, and underinsured women. And as was mentioned earlier, the number of uninsured women are going up. Over the life of this program, we provided 15 million screenings to women who would not have otherwise had access to care. And regarding racial and ethnic minority women that we serve, 75% of the women we serve in our program are currently now within Hispanic, Black, Native American, with the rest being white women. So CDC also promotes prevention and screening through our colorectal cancer control program. This is a health systems program in which we go into clinics and implement evidence-based interventions and then see how they work and how screening improves. So over the life of that program, health system and clinic screening rates improved 14%, which it represents 92,000 colorectal cancer screenings for those who need it the most. And so I would like to end by saying between 30% to 50% of all cancers are preventable. Prevention offers an effective long-term strategy to stop cancer from ever happening. As we look to improve health equity, prevention and early detection must be a part of the equation. I look forward to discussing strategies with the other panelists as to how we can prioritize prevention amid other urgent health concerns, such as COVID-19. Thank you.
Thank you so much, Dr. Richardson, and all of the panelists. What a lot of great information you all were able to share on the importance of screening and the impact of COVID-19 on cancer screening. So now we're going to spend some time doing some question and answers and get a little bit more information that we can share with you all about this important issue. And so I'm going to start with Dr. Fedwa. You presented in your presentation data on unemployment and cancer screening. Do we know how unemployment or job loss might ultimately impact cancer outcomes or death?
So that's a good question. And I actually was reading about what happened during the last global recession when we had high unemployment rates. So this kind of looks at a population level. There was a nice study done looking at how the global recession impacted cancer mortality in different countries. And what they found was that cancer mortality had increased, including cancers that are screen detected. But in countries that have universal health care, that these increases in cancer mortality were dampened. Unfortunately, that's not the situation in the US, but that kind of gives us a little bit more information about what universal healthcare coverage can do in challenging economic times and how it's related to cancer mortality.
Great. That's really helpful. Thank you. My next question is for Ashley. Ashley, you mentioned that the American Cancer Society is working on 12 community projects, and volunteers and community members are figuring out ways to address social determinants of health within their various communities. Can you briefly discuss a specific project that you're working on in Jackson, Mississippi? I hear it's a really great project with a lot of impact. If you could just share a little bit, that would be great.
Yeah, thank you for that question. I think the folks in Jackson will really be excited that they were shouted out through our community project. I'll add that our community projects are really community-based initiatives where we work with staff and ACS staff and volunteers and community members to determine which social determinant of health they want to focus on as it relates to cancer. And in Jackson, they've wanted to focus on addressing food insecurity because they know that it impacts risk factors related to cancer. So they've really taken the initiative and thinking through who are the community partners they can work work with to address food insecurity. But then COVID happened, and they had to address some immediate needs in that community. And I think that's the heart of our community projects. We're really meeting communities where they are. So because of COVID, our community project in Jackson has actually pivoted to meet immediate needs and feed folks through a mobile pantry unit. So they're going across the city of Jackson and feeding especially kids when they were out during the summer to make sure that they were fed, and adults as well, their parents. So we're working with communities to figure out what the next steps are, but this is really an opportunity for us to learn and grow with the community to address some of those social determinants of health.
Yeah, that's really great. Thank you for sharing that. It really does show how every community is different and every community's needs are different, and what a great example. Thank you, Ashley. The next question is for Dr. Richardson. So could you just spend a few minutes talking about your biggest fears around cancer screening in a COVID-19 environment? Ashley just said, and COVID happened. And we all know that everything has just shifted and we've all completely changed how we approach things. But could you share your biggest fears since you're so close to this?
So a couple of things that Dr. Brooks said earlier is that, I think that there are going to be long-term consequences of screening dropping so low for so long. And even the best data we have looks like it's 60, maybe back up to about 60% of what it was. So the backlog is going to be tremendous. But my biggest fear is how are we going to convince people to come back in for care, types of care? And the main thing that, so one place to start might be symptomatic people. If you have symptoms, people have been dying of heart attacks and strokes at home. So that's something we can identify. And so with cancer, people may not see it as, that urgent, but recognize the symptoms of cancer, something we've been working on for years, and also to come in for care. And on the fear side, one of the things I think we're seeing in our BNC program and talking to our program directors is that people are just scared to death to come in for care of any kind.
Right.
And really to come in and start working on that angle of helping people feel more comfortable about the care. COVID is so different in every community. You can't really put out a blanket statement about what you should do. And I think those are the challenges, and people like ACS on the ground everywhere. We have programs everywhere. We really do have to keep our ear to the ground, as Ashley said, about what's going on out there.
Great, thanks for sharing that. Really helpful. Dr. Brooks, the world is mourning the loss of a superhero, both on and off the movie screen. And we know Chadwick Boseman's untimely passing has sparked a lot of conversations around colorectal cancer. As you know, there's a lot of stigma around colorectal cancer in the Black community. Will you share some insight on the importance of early screening for colorectal cancers, especially in the Black community? And then also, if you could offer thoughts on peer-to-peer community programs that may be helpful in reducing stigma.
African Americans are about 20% more likely to be diagnosed with colorectal cancer and 40% more likely to die of the disease. And there is little, if any, evidence that those disparities, particular mortality disparities, are related to anything genetic. It is really all about behavior and access to healthcare and taking advantage of that access. It's imperative that people recognize that colorectal cancer is one of the few cancers we can actually prevent through screening. So by getting screening tests done, we can find and remove precancerous polyps and keep people from ever getting cancer. But even if we miss that opportunity, when we screen people, we have a greater likelihood of finding the disease in early stage. And early stage disease, 9 out of 10 of those people are going to be alive 5 years later, and many of them are going to be cancer free. On the other hand, if people don't get screened, if people wait until symptoms show up, in many instances, they're going to have much more advanced disease, and advanced stage disease is much harder to treat and ultimately is usually going to have worse outcomes. So African Americans really need to appreciate that colorectal cancer is something, it is preventable, it is beatable, and it is treatable, but it really starts with getting screened. There also is a familial component to this. Most people who are diagnosed with the disease do not have a family history of it. So just because it's not in your family, to your knowledge, doesn't mean you ignore getting screened. But if you do have a family history, it's even more important that you talk with your healthcare provider and start getting screened earlier in most instances. And it's important that families share with one another. So if someone knows that they had colorectal cancer, or even more importantly, if they know that they had a polyp, they need to make sure that they broadcast that broadly and let everybody know. That's not something you keep to yourself. One of a survivor who started an organization called the Blue Hat Foundation has a saying, family secrets kill families. So let's not keep those secrets. With regard to peer-to-peer, there are a number of different organizations out there that are focused on helping educate people about colorectal cancer and colorectal cancer screening. And also even will, in some instances, help people find links to get screened. They'll help make people aware, for instance, of the CDC programs that Dr. Richardson talked about, and other programs, the Change Grant programs that Ashley described. But I would recommend that people start by visiting the National Colorectal Cancer Roundtable website, nccrt.org. There's all sort of information out there about organizations that are fighting colorectal cancer screening. The CDC website, the American Cancer Society website, all of these have links to a lot of different important information and organizations and resources.
I'd like to add to that, because really the shame is the cancer is preventable. And it really doesn't have to happen for almost anyone. And there are special cases, but yeah, Dorada's absolutely correct.
Really helpful advice, and I'm sure that you're providing information and insight to people who maybe didn't have answers to some of these questions. So with that, I'm going to thank all of the panelists today to talk about this extremely important issue. I want to thank CBCF for allowing us to be able to highlight cancer screening and looking at it through the COVID lens. This is something that we're going to be talking about for a while. It's not over, and we are going to be being very clear and conscious in understanding what needs to be done to make sure that we can continue to save lives, and we know screening saves lives. So with that, thank you again to all of the panelists. I appreciate your time, and thank you all for joining. Hopefully you're walking away with a little bit of tidbit or information that you didn't have before you tuned in. Thanks everyone, take care.